Hello to all the HubLE audience. My name is Niloufar Ansari. I'm a postdoc at Monash Institute of Pharmaceutical Sciences in Australia. I'm also an editorial board member of HubLE. I'm here today for an edition of Meet the First Other with Dr. Alexander Rodriguez. Alex is a medical student at Griffith University in Australia. He completed his PhD in 2019 at Monash University, and he's now adjunct postdoc at Monash University too. So today we're going to talk about his paper recently published in the Journal of Clinical Endocrinology and Metabolism, titled Oral Bisphosphonate Use Reduces Cardiovascular Events in a Cohort of Danish Patients Referred for Bone Mineral Density. So welcome, Alex. To start with, can you tell us a summary of your work and how does this fit in the big picture of the field?
Well, hi Neil, and thanks for the invite and the opportunity to speak. And I hope this paper is of interest to the audience who might see this video. So as the title, you shouldn't judge a book by its cover, but I guess in this instance you can. So what we showed was that in a group, a big population sample from Denmark, we showed that individuals who went to go get bone density testing, those that ended up on treatment with a bisphosphonate, oral bisphosphonate, and in this instance, 96% of the people in this cohort ended up on alendronate, which is the oral formulation for bisphosphonates, we showed that compared to people that didn't end up on bisphosphonates, they had about a 33% reduced risk of cardiovascular hospitalizations, which we assume to mean cardiovascular disease. So I guess this is quite significant because for quite a while now, we've learned to appreciate that people with osteoporosis are at an increased risk of not only general mortality, so just dying earlier than people without osteoporosis, but it seems that the cause of death, the cardiovascular causes of death are overrepresented as a cause of death in people with osteoporosis and people that have fractured. So I guess that leads to the question is, well, if you have bad bones and that's bad for your hearts, can treatments that modify your bone, modify your skeletons and modify your fracture risk also have some effect on your cardiovascular risk and mortality risk? And there's been quite a lot of interest in this topic, gathering momentum probably over the last 10 years or so, and particularly now with all these new agents for osteoporosis sort of falling over at the approval stage because of cardiovascular disease risk. So I guess this feeds into all that literature. And what we showed was that the oral formulation of bisphosphonates, which are widely prescribed both in Denmark and in other places around the world, showed that they have a good cardiovascular safety profile. So that's a sort of like clinical interest of this paper. There's also patient interest, I guess, as well. In an age where you can just sort of go online and, type in the name of the drug that the doctor prescribed to you. You can go to Wikipedia, you can go to Pete Evans' blog if you wish, and learn about all the nasty things that our doctors are feeding you. So patients come into their appointment or their consultation with their doctor armed with all this knowledge. And a lot of the time that knowledge is misinformed, and patients are very interested, I guess, in what I've sort of termed the off-target effects of medications. So obviously we're prescribing a bisphosphonate, that's for your fracture risk, but patients might be interested in what else do these drugs do. So it's really good from that aspect as well, is that a doctor can go to their patient and say, well, these drugs are not only good for your skeleton, but they also might have these other beneficial effects in terms of heart disease.
Yeah, that's a good point that you mentioned. Like nowadays, a lot of patients have a lot of information about the drug, which I think is a really good thing because it shows that they are careful and they want to be engaged in the whole process of treatment. My next question is about the challenges you encountered with this work. What were the main challenges and how did you overcome them?
Well, I mentioned just at the end there that, at least in an observational setting. So if you're doing anything clinical, using people instead of, an animal model or a cell model or something, the whole issue of causation, are we witnessing a true effect, sort of comes into play. So the biggest challenge here was trying to design a study that, as best it can be in an observational setting, demonstrates as best it can some form of causality, because it's not a randomized trial, so we can't actually say that this causes that. We can only say that this is associated with that. And so I guess one of the unique aspects of this study was that all the patients enrolled in because it's just a population sample, all the patients that were enrolled into this study were recruited from a single centre, and they all had bone density testing. So unlike any other previous study in this area looking at this particular question, all the patients, the term I used in the paper was, they all shared a clinical indication for bone density testing. So that's something that's very unique to this paper and hasn't yet been replicated in other similar studies. So there's, the treatments and the control groups were, I guess, matched a priori. So that was really important for the biggest challenge of this paper, which was, getting around that question of causality. I guess we showed that right from the get-go, the patient groups that we were comparing were very well matched and very well suited to each other. That was a sort of scientific challenge, but I guess, there's also personal challenges as well, which I think you're sort of alluding to. So I was lucky enough to receive a grant from the ANZ BMS, the Christine and Jack Martin Research Travel Award, and that enabled me, that was quite a significant grant actually, and that enabled me to actually travel to Denmark and actually be embedded with the team there. So Professor Bo Abrahamsen, I was hosted by him and his team at the University of Southern Denmark for about 3 months. And with them and the team, I sort of learned all these, a little bit of coding and other statistical things as well. And as well, I should also plug the Bone Research Society from the UK, who also gave me a little bit of funding to help the travel as well. So, it's all well and good having these collaborations and, we're obviously meeting, over Zoom, but nothing compares to actually being there with somebody, learning side by side from experts and people who just have completely different skill sets to your own. So that tyranny of distance, I guess, was helped overcome by those grants.
This is great to hear that you received those grants. We're all having problems in getting funded and in getting grants, but when you see that people who, like you, who deserve to be supported, get those support, and the outcome of their work would be something significant, like your paper, it's very happy moments for all of us as early careers. So Alex, what do you expect the outcome of this work be for future patient work or clinical trials or further study in the field?
Well, I'm really developing quite a keen interest in this whole idea around, do osteoporosis medications have effects outside the skeleton? So that's something that I guess want to dedicate the next 3 to 5 years to better understanding, but in a clinical sense, I guess. So I would like to, instead of just looking at, say, hospitalizations, which is just using medical records or something, it would be nice to actually look at, in patients that take these medications, what's actually going on in terms of their cardiovascular system. Are there changes in blood pressure? Are there changes in calcification? I know a group from Tasmania recently did a bit of work in this area. Are there changes in other hemodynamic or arterial properties? I think all those are really unexplored areas. So I guess I should say, if anybody's working in these areas and they want somebody to come and, pitch some ideas to them, I suppose you can just flick me an email anytime.
So you published in Journal of Clinical Endocrinology and Metabolism. How was your experience for publishing there?
Overall, I think it was quite good. I mean, they're quite a reputable journal. When I sort of think about where do I want to send a paper, I don't just look at impact factor. I mean, obviously that's really important. I mean, we can't get away from that fact. For all of its flaws, impact factor is sort of here to stay. So that does come into consideration. But you also want to look at what's the reputation and the readership of the journal. I guess one of the qualities of the JCEM, as it's shortened to, is that it's the flagship journal for the Endocrine Society in the US, which is the world's largest endocrine professional society, I guess. So then you're publishing with the prestige of that organization behind you. So I think that's an important consideration. And that also extends to then the readership, that all those members would presumably be reading that paper. Also, the thing about JCM is that it has a good mix of clinical and laboratory experimental research as well. So you're getting a more general endocrine readership. So all those things make a JCM a good place to put something like this there. But I guess, most of the negatives that I have with this journal, just like any other, I guess, there is a protracted waiting time with, hearing back from reviewers and whatnot. But I guess this year's been very special because of the COVID-19 pandemic that the world's been inflicted with.
So in terms of your career, how does this specific paper going to help you, Alex?
Well, I sort of mentioned before where I sort of want to take this work and my work over the next sort of 3 to 5 years, really understanding the cardiovascular risk of people with osteoporosis that happen to be taking these medications. And I think there's a real groundswell now, both in the literature and in support, emotional support, I guess, from a number of eminent researchers around the world in this space, that I think it really is time to have a look at doing a trial of these medications, looking at outcomes other than skeletal-related outcomes. So I mentioned, these blood pressures and those things before. I'm thinking that's something that could be done, and I would love to do this interview again as the first author of that paper potentially, but who knows where life's going to take us. So yeah, that's something that I would like to dedicate the next couple of years to. You mentioned before that obviously a medical student now as well, so that idea around patient safety is really important to me as well. So I think it's our sort of duty, as physicians, as a future physician, to properly inform patients about all the potential risks and benefits as well of treatment. So I would like to go into any conversation with a patient and be able to say that, oh yeah, this, take this because it's going to do this, but then also understand all these other things, whether they're harmful effects or beneficial effects. So I'm not sure how many conversations I had between a doctor and a patient with osteoporosis, and whether their cardiovascular risk comes up at all in that conversation, when I think that maybe it probably should, given what we know now about the effects of bisphosphonates and other medications on cardiovascular disease.
Those are great goals, Alex. Wish you best of luck, and we look forward to hear more about you and your group work in future. And thank you for taking time and discussing your work with us today. I also like to thank the HubLE audience for taking time and joining us today. If you would like to be involved in the Meet the First Author initiative, please feel free to contact us through huble.org. And also follow HubLE on LinkedIn, Twitter, YouTube, and Instagram. Thank you.
Thank you.
Thanks, Alex.